Welcome to Everything Digital Health. This morning I've got Rachel Dunscombe, the CEO of openEHR International, with me. And we're going to talk about openEHR, the standard, and possibly even why people call it openEHR or openEHR or those kind of things.
Thanks for having me.
First of all, Rachel, would you like to introduce yourself to the viewers?
Yeah, so I'm Rachel Dunscombe. I'm a recovering healthcare CIO from the NHS. Also visiting professor at Imperial. I used to lead the NHS Digital Academy. Now I'm CEO of openEHR International, really because of my learnings as a CIO and the increasing importance of data in healthcare.
Cool. So openEHR International is a standard setting body, I guess, isn't it?
It is. Yeah.
But it might not be something that all the viewers are familiar with. And they might have only heard the word or heard nothing about it. So how would you describe openEHR?
Well, what I'll tell you is it's not an open source EHR. A lot of people think it is. Basically, it is the data layer that is what we call semantically harmonized. So it's the data layer that describes all of human healthcare. And it means you can carry a longitudinal record with you for a citizen, for your entire life, and your whole record is there and meaningful. Or for a population, you've got all of their records in a meaningful way that can move across boundaries, be it within a country or internationally. And one way we kind of describe it is it's a bit like Lego. So, I think of my old EMRs that I used to run, and they'd have blood pressure in so many different formats and all the concepts in lots of different formats with different fields. It has one, sense of truth. So if you take blood pressure, there's one archetype for blood pressure that's the same, but then it uses templates to actually surface that for use cases. And that means if you want to trend the blood pressure across somebody's life, it's always got integrity. So as we get into this world of AI and, cognitive intelligence, you need to train on concepts that have integrity. And so it's increasingly important. For that reason, it's also increasingly important because patients are known to, a lot of different providers, and we need data to be able to have a single sense of meaning across those providers so that we're clinically safe. So openEHR, I guess for me, was a learning from my CIO work around the fragmentation of data today and the risk that poses in terms of, delivering high quality care, but also look into the future where we're going to be 15, 20 years. We're going to need great data to enable the tools that we'll be using.
Cool. Yeah, I think so. So openEHR is a kind of interoperable set of data models,
Yes.
Rather than, as you say, it's not an open source electronic medical record, electronic health record. And there are such things out there. So there's like openEMR, openMRS, hospital. There's a whole bunch of these things out there. Often they're, at least initially, they're tailored for either small clinics or kind of use in the third world kind of thing, where there might be one laptop in the entire building and you do all your computer work in that. And some of them are pretty mature projects. I mean, openMRS has been going for 20 plus years.
It's great.
They are complex, and they handle billing, and they can do all those kind of things. But openEHR is explicitly not that thing. It's not aiming to be a full stack with a UI and all the tooling that you'd need to be an out-of-the-box medical record, which I think does sometimes surprise people, because I think when I first got involved in this world, it surprised me. I think I was advised when I was building the open source GP system of the future. People said, "Oh, you must use openEHR," and I thought, "Great, well that's going to save a load of time." And actually, it wasn't quite as simple as that.
Yeah,
but
absolutely.
It does do certain things for you, like standardizing some of those data models.
Yeah, I mean, really, this is about separating data from applications so that you can have multiple applications working over the same data. And so it's really well engineered for the future, because data that we record now will be used, hundreds or thousands of different ways for an individual over their lifetime. And so, engineering that separation of data from application is the way that we're going. And openEHR is that data layer, but it's not the application layer. There are some great people that have written EMRs on top of openEHR, but we don't, as the standards body, do that. We concentrate on the data layer.
Yeah, it's a little bit like, say, SNOMED or something like that. It's a tool that you need in as an ingredient in an electronic record, but it isn't the whole electronic record.
Absolutely.
So I think it's worth probably touching on what is data modeling, and why is there a need for a standard data model? Because I guess if you look at electronic systems that you might use, if you're a clinician and you're working in a hospital or something, you'd think that there'd be some standard way of saving all this information. A bit like, if you're writing in a Word document and you click save, you get a docx, and that's kind of a standard item of saved data. But we don't really have that in healthcare, do we?
We do not. There is huge variance. And I've done some of this work to actually, look as the CIO and with health systems as the CEO of openEHR at the variance, even in simple concepts, right? It becomes very lossy because the schemas that we use to store it are not consistent, right? And they don't have the same meaning. And so data modeling, openEHR uses both clinicians and technical experts, and a kind of Delphi process almost globally where we get consensus about what needs to be recorded. And that is really important. The reason is we are now getting lots of things like the International Patient Summary, the European Health Data Space, all of these things where records are becoming portable with people to make their healthcare safer as they, travel for work or move country or go on holiday, whatever else. Great example that I've been on the periphery of recently is NATO forces in the International Patient Summary. Yeah. So in the battlefield, if you're from one force, but you have to be taken to another force's hospital, they need a single way of describing, somebody's health record across all of NATO forces. And so really this is about, delivering quality, safety, but also allowing people to be in control of their own record as well. So if you think about all of the providers you're known to, I'm thinking about how many healthcare providers I've had in my life. There are people that have had far more than me. We need all of that data to be consolidated down into one record. And so that needs a single standard and a single source of truth, which is openEHR. Now, we did have, in the past, things like V3, HL7 V3 RIM, which I also have used with DB Motion in the past, which was similar, but that has not really been maintained. So, we haven't got, this is why I got involved in openEHR, because there aren't really many options, but you really, really need to do this.
Yeah, I think people get overexcited about the XKCD, so many standards cartoon type thing when we start talking about standards. But actually, we are not in the position where there are, 17 competing standards.
No.
There's actually no standards really that are 100% ready for the prime time. There are standards that are close to it, like FHIR and openEHR and SNOMED. But none of them on their own appear to be the entire solution that you need, kind of thing.
So we don't want that either, as in, I think, in the past, standards bodies were very standalone, if you like, and they overlapped a lot. What we've seen now with the Joint Initiative Council and the partnerships that we've got with SNOMED and HL7 is really that we are stopping any duplication and we're making them more complementary. And just to be clear, those standards all work really nicely together. And going forward, it will be even neater. So, SNOMED is the codification for things like diagnosis, procedures that you can embed in openEHR. And FHIR is really the web APIs that does the 80-20 rule that transports sort of, data. And by 80-20, I mean it can, meet about 80% of use cases. Some simple storage can be done in FHIR, but if you want really extensive storage that can deal with the whole human health record, openEHR is the only thing that's really got the possibility of doing that. Yeah. So in saying they're not ready for prime time, I don't think we haven't completed this journey by any stretch of the imagination, but it's really good that we're partnering now to actually ensure that we're dividing up what needs to be done in the standards bodies and saying, this is something we're going to deal with, this is something you're going to deal with, and then really creating complementary guidance to make sure that standards work together. But we need different standards, partly because they're different communities, right? So, if we think about, FHIR, it's a very technically driven community, speed to value. It's about, actually transporting data. So it's got a real technical skew in that sense. If you look at our community, it's really about the definition of data that's needed for human healthcare. So it needs a huge amount of clinician input and peer review. And if you look at SNOMED, it's really about definitions of, all of the things in healthcare at a codification level. And really interesting, talking to somebody that's been working on traditional Chinese medicine and the definitions there, that's very different to the kind of things that we do. So these communities do what they're best at, but then we're making a complementary whole going forward. So I think that the past couple of years for me have been really nice to see the standards bodies finding ways of working in a more complementary way and a less duplicative way as well. So it's becoming clearer. I've got to say, going back 10 years, it was slightly confusing for me, but things are clarifying.
Yeah. Well, I remember 10 years ago, it felt very much like there was competition. So
Yeah.
it was either FHIR or openEHR, and there was lines being drawn, the battle lines between the two, as though it was one or the other. And as you've explained, it isn't really one or the other. openEHR is definitely preferred for your kind of persistence, and FHIR is an interaction kind of interoperability layer.
Yeah.
So you can imagine if you have an electronic medical record that uses openEHR for its persistence, but has to interact with, say, smart measurement tools, for example, it could interact with those smart tools with FHIR.
Yeah, absolutely. And that's how they fit together. And, if we continue like partnering in this way, I think we'll get to a really good point where those standards will be informing each other, and it will get ever easier. Oh, that's my hope. That's why I'm here to make it easier for health systems.
Yeah, I think it's worth just mentioning what happens in the wild west of health software when you aren't using a standard, just to sort of explain the opposite scenario, which is when I decide I'm going to write a hospital medical record system. So I just start doing it. And like all database-backed systems, I think, well, it's going to have a way of saving the patient's demographics, for example. So I just start coming up with fields off the top of my head as a developer, and I'll make some sensible decisions. I'll also make some unwise decisions just out of random chance, really. But one thing that's guaranteed, however good I am, my data model will be different to everybody else's data model that's
Absolutely.
also gone through the same process. So if we're looking at big systems that exist, whether they're Epic, Cerner, Allscripts, GP systems like TPP System 1 and EMIS, all the big systems that we use across all of healthcare have all essentially gone through an independent, completely isolated data model procedure. So they have got a data model that's unique to their platform. And you can't just take an export of data from one major electronic healthcare provider's system and upload it into another one. It doesn't work.
Absolutely. There's research out there that says less than 30% of that data between different vendors can actually be brought together. You lose, it's lossy, around about 70% of that data between different vendors. And that's all published research. And that is exactly why, I got engaged with openEHR and why I do what I do, because losing data, means that we're losing the safety of the care we deliver. And that for me is kind of like, it's a safety and quality issue, massively.
Yeah, it's huge. And it's not really talked about either. So
No.
we seem, as a health tech community, to be very, very interested in new installations of software in new trusts. And I guess because the industry is quite sales-led, quite industry-led. So if you look at what digital health news articles there are, so there are a couple of websites that you might go to for digital health news. You know, there is Digital Health itself, there's HSJ, and there's other similar platforms. There's the HTN, but they tend to report on new deployments of stuff, which is all very exciting for those places. But no one's talking about how they're going to get the old data into the new system. And even more importantly, when this new thing is no longer new in 20 years' time and they want to get off it, how are they going to get off it? Have they planned for the eventual obsolescence of that system that they've just bought? And nobody's doing that. People just buy stuff, and I think they just feel lucky to have got the thing out the door. You know, they've managed to get the procurement done, and it's a lot of work, and it's hard to do. So they're pleased that they've got to that stage. But actually, there's a whole level of thinking that often isn't done, which is how will we get our data out of this system when it reaches end of life?
Absolutely. And I call that data debt, right? A bit like technical debt. You're building this whole set of pain for yourself, be it when you want to get off the system, as you said, or be it when you want to do, you know, a kind of time series or a, you know, training AI, which may be, you know, before the 20 years when you get off it, and you find that your data is very lossy, incomplete, the data quality is poor, you don't have the right schema. It's basically, I can't, you know, necessarily just blame health systems, because there's all sorts of pressures. We don't necessarily have all governments mandating standards and saying why they're important. And that is something that I think increasingly governments are realizing, but they've not really created a landscape where that's been part of the policy in many cases. So that's one thing. You've then got the likes of your finance director, as you know, I would have known it, saying, buy the cheapest thing, buy the thing that, you know, has the nicest interface for the clinicians. So a lot of scoring in procurements where they say, how nice is the interface for the clinicians, or does it deal with voice driven? And the really interesting thing about data is that it's becoming the infrastructure of the future. So traditionally we delivered care in hospitals, and that is critical infrastructure, capital infrastructure. It's bricks and mortar, glass and steel, whatever it is. But it's, you know, something that lasts 50 years, say 100 years, and it's a building which you deliver care from. Well, now we're increasingly needing to and wanting to deliver care in or near the home. The equivalent of those bricks and mortar buildings is actually the data. That is the infrastructure that enables that, in the way the bricks and mortar has done traditionally. And having robust, well-engineered data allows you to deliver services in the home via, you know, medical devices, apps, wearables, you know, in distributed models. And so we need to think about data in the way we think about our buildings. So we engineer our buildings well. We engineer them to ISO and other standards. We engineer for longevity. We think about the use today and tomorrow of those buildings. But we need to do that for our data, because it is going to be the virtual walls of the elastic hospital or the elastic health system. And there are quite a few people who are starting to get this now, that data is the future infrastructure for healthcare. It basically allows us to, you know, reduce this trend that we've got of actually increasing the number of people that are in hospital by doing that activity in the most suitable venue of care, which is lower cost. So we've also got this issue that most healthcare systems are not sustainable financially with their trajectory. And so we need to do this. We need to go to lower cost venues that are often more suitable for the patient, more convenient. For me, it's the future infrastructure for healthcare, which kind of is why openEHR for me has absolutely got a place in creating that standardized infrastructure that is the data fabric, if you like. And it's the equivalent of all the building standards that you've got, you know. When you build a a building. It's really hard though, if you work with boards or senior leaders, they can see a building as it's built, but you have to build pictures in people's head. And one thing Heather Leslie has done, which is fantastic, is through the kind of whole Lego metaphor for openEHR, because you need to help build pictures in people's head for them to understand how important this is.
I like that building metaphor, because as you say, it's quite difficult to conjure up in people's minds what we mean by standards, and why standards enable things to be done much more safely, quicker, and with a certain amount of sort of ubiquity of feature set as well. So, you know, if you build a brand new office block, there are standards in place that mandate certain things that have to be in there. So it has to be safely built, but it has to have toilets, and it has to have cooling, and there has to be things that are built into that house or that building that are required by law. And we don't yet have those standards for healthcare. But if we did, then it would mean a lot more ubiquity of feature set. And because one of the things that we miss is some systems, if you go to one hospital, you've got one system, one set of guardrails for clinicians and one set of tools for them. And then they move to another hospital, which all doctors have to move in their training. And at the new hospital, they don't have the guardrails because that's bespoke to the previous EHR. And that's risky in itself. If you have a guardrail and a safety feature on one EHR that is not present on another EHR, I guess it's like the difference between, you know, cars 20 or 25 years ago didn't necessarily have anti-lock brakes as standard. And now it's illegal to sell a car that's new that doesn't have those kind of safety features. So we continually add better and better safety into cars, and we make them standard, and then everybody can assume that they are there. Whereas jumping from one car to another, that one car does have the safety standard, the other car doesn't have the safety standard, that's almost more dangerous than not having the safety at all.
Absolutely. And you know, you picked up on the car industry there. If we look at aviation, it's similar. You know, lots of other sectors have got this minimum standard platform, right? And they've also got, you know, data standards globally. So if we look at, you know, immigration and passport control, if we look at air traffic control, if we look at, you know, military, if we look at maritime, they all have global standards to describe these things. Healthcare is a bit behind, and I think openEHR is part of that jigsaw. It's not all of it. All the other standards fit in and policy fits in and things like that. But I think healthcare has got to catch up with other industries which have got minimum standards for human safety, right? Because it's a life critical industry, just like the other ones I mentioned.
Yeah, absolutely. I think if we had those standards, then we could spend a lot less time worrying about data moving between places. That's something that we shouldn't have to think about at all. That should just be done. That we know where our data is, and we know how much data can be stored about a patient. We know where that's stored. All of that kind of data layer about a patient should be something we can essentially forget about and move it into a commoditized layer that is not something that we spend a lot of time on. Whereas at the moment, interoperability is something we spend a lot of time and effort on.
Oh yeah.
And that's wasting clinical time worrying about where data is. I want to be in the future where the data is a given, and then we can actually start thinking about innovation in terms of user interfaces and what I can do with that data.
Absolutely. So I guess the frustration for me as a CIO in a healthcare system was we spent so much time with this feral data wrangling. You know, there would be teams and teams and teams of people trying to, you know, shape things in, integrate things. You know, it was a whole industry in its own right. I, as a CIO, didn't want to be spending all my time that I was spending on that. I wanted to be helping redesign model of care. You know, I wanted to be creating the future sort of models that were informed by data that allowed the health system to progress. And so really not having this standardized data layer is holding back health systems from progressing because people's cognitive load is just too much dealing with the mess, if you like, that there is. And
Yeah,
I think we
really
need to do this piece so that we can progress, right?
Yeah, I mean that what I've heard this described as human middleware. When the data is not in the right places, we end up having to use humans to provide the interoperability where the interoperability should exist in the computers but doesn't.
Yeah.
So that's where you get a clinic administrator having to copy stuff out of a patient administration system into the EHR so that the consultant can see the information that's in the PAS, and this kind of back and forth of data being done with copy and paste, what I call soft interoperability, is
Scary interoperability. It's dangerous because
it's
mistakes can be made, right?
yeah, and that's all because of the lack of standardization of that data model.
Yeah.
Um,
We have a cleanup job to do because, as I said before, going back to the 90s and early 2000s, healthcare systems were incentivized to buy what was most economic or cheapest, or at best, what looked good in terms of user interface. That led to, I had run about 1,000 systems as CIO. So we had this huge variance. We've got this huge basket of things that need to be tidied up over the next few years to something reasonable, to enable a future to happen. And unless we get ourselves into the standard space, we're not going to achieve that. And our money is better spent on technology solutions that enable care as opposed to all of this kind of wrangling and munging of data together. It's a really ineffective way of doing it. You wouldn't design it this way. It's not engineered in any way. It's kind of accidental.
yeah, uh, I've had some recent conversations that were very interesting about archiving, um,
Mm.
and the parallel there is that a lot of our data is critically endangered, as it were, in that I know for a fact, just to take an example of a concrete system that I used to use, when I started my GP training, I used a system called Torex Synergy,
Oh, I
which
remember
is an
Torrent.
old GP system, yeah, that was leaving the market as I was learning to use it, actually. And it was falling apart. It had 10-second lags on menus to pop up and things. It was broken, essentially.
Mm.
But when it left the market, some of the data was migrated into the successor system, which was TPP System 1, but not all the data. And critically, a lot of the really detailed data that we would need to catch a shipment, for example, is
Yes.
the audit trail data, and that they weren't able to find a way economically. It's always the weasel word. Economically, they couldn't find a way to move that data. They could have done if they wanted to, but they just couldn't be bothered. So a, a slim, sort of lossy layer of data was migrated across. A lot of that stuff, which would have been structured data in the source system, becomes just plain text in the
Mm.
destination system. So that's a degradation from a structured
Yes.
data object to plain text, which makes it less useful, less searchable, less auditable, and that sort of thing. And the audit trails were left on Torex Synergy, which was on a physical server in the practice building. And the plan was to just leave it there. And if we ever needed to go into that, so if we were catching a shipment, we would have to just hope that future updates to the operating system or whatever, that somehow magically that server would still work, the disk would still spin, the application would still boot up, and we would be able to get into the audit trails. Otherwise, it would be an incredibly expensive forensic data
Mhm.
expedition to get that data out. And that's just one example in one area, in one practice. And that's happened across all of general practice because almost everybody used to have an on-premise system and moved to a cloud-based system. So a lot of those systems will have been migrated at some point and lost a huge chunk of their audit trail data,
Mhm.
and so the actual clinical data will have been degraded from a structured data object into free text. So that is an example of how every time we move systems, we're losing data. And no one is talking about the archival in any kind of future-proofed format of these records. And you might say, well, it doesn't matter because, over time, the utility of that clinical information gets less and less, right? Because we're only really interested in the stuff that's happened fairly recently to patients and that sort of stuff. But it forgets about the fact that we might want to do research, like lifelong research, where the data is gradually degrading. So the further back you go, the less useful the data is going to be. And also occasionally you do have clinical utility to very old data about a patient. You want to know what batch of a particular vaccine they had 30 years ago, and you won't be able to find that if we let the data degrade at the current rate.
Well, under GDPR, we have a right to all of the data about us. This is something else nobody talks about, right?
Yeah.
Right? And what if I want to donate my body and my data to science at the end of my life? I wouldn't be able to get all of my data because, as you said, it's in standalone, PCs sat under a desk in a GP practice from 20 years ago. You also touched on shipment, and it's 21 years, I think, isn't it, for a pregnant woman? You've got to keep her records for her and the child. There is good reason for that. We need these sort of, these data assets to be available for many reasons. That one you gave me about longitudinal research, I've just, I've just been talking to some people who are working on a project who are taking people with rare diseases and going back through their record to childhood to look at the first signals of a rare disease being there. In that case, it's around sort of, UTIs and things in childhood. And we're missing a trick here. We're missing a trick both on the sense that data has value for everything we need to do, but we're also missing a trick on the fact that legally we have to provide data to our citizens. It's their right to have it. As a citizen, if you've got a rare disease or cancer or whatever, you may want all of your data to, participate in research trials, whatever else. There are many compelling reasons. It makes economic sense to do this well. It will be cheaper if we marshal our data well. We will have a safer system, and our citizens also have a right to this data. So from every perspective, it makes sense. But I just don't think that people see it clearly in their heads. It's really interesting if you go into a boardroom or whatever else and you say to health system boards, right, you're all sitting here now, but say it's 20 years time and you're retiring. What kind of health system do you want when you retire? And you just run that through with them. So, it's what do you want, as you're getting older to support you. And then you look at where we are today and you point out the gap to get there, because without a doubt, they want the data available. They want to be able to utilize things that will really, assist them in being independent as they get older. We've got a journey to take, and we need to get from where we are today to there. And for me, that's quite a clear journey of countering all of the history that we did with good intent, but we need to counter that and move to something that is well engineered for the future and will support everything we need to do. But there doesn't seem to be anyone articulating that journey, particularly in most health systems. And that's really a frustration for me, because I feel I can see it and I feel I can talk to, say, boards about it. But I think the chronic short-termism in some health systems, the political cycles stop people from actually trying to deal with what they need to do long-term. At the end of the day, in countries where we can build motorways, train networks, other things, which are like 20, 25-year investments, we need to see this as a similar thing. It's the architecture for the future of our country or our nation. Yeah. So, it can be a little bit hard when you, I guess, have spent time like I have thinking through this, talking to policymakers, looking at the metaphors and the parallels. in terms of other bits of infrastructure. But at the end of the day, I think it's going to be very interesting if citizens start realizing that they can demand their data. Because legally they can.
Well, they can make a subject access request and they can get a copy of their data. And sadly, almost universally, that will be printed out onto paper, and just a big pile of paper gets sent to the patient. Not in a form that they can do anything with, not in a form that they can do their own analysis on.
Well, it does say in the legislation in a suitable format. And I think if enough citizens start pushing on what is a suitable format, paper is not suitable in this day and age, it's going to force health systems to think, how do we get that unified record?
Yeah, I think that's absolutely the way that we've got to take it, really. So thinking about the future then, you know, you're the CEO of openEHR International. I'm involved in that organization as a sort of helper, sysadmin kind of person. So I've seen some of the real improvements that we've seen over the last couple of years in terms of turning it into more of a professional body and less of a sort of hobbyist club type thing, if that isn't too rude to say. But it was certainly, there was a lot of stuff that needed to be kind of professionalized and brought together. We've had a conference, an international conference last year that was very successful. So what do you see in the future for openEHR?
Yeah, you're right. Last couple of years, we've moved from being, you know, volunteer driven to being a mix of, you know, appointed professionals supporting volunteers and having proper, robust governance. Also, you know, becoming liaisons to SEN and ISO and other things like that. So really being part of the international standards scene. So where do I see it going? What I'd love is that, you know, as you just said, we quietly become this standard layer for, you know, data across the globe for human healthcare, and that, you know, countries, we've already got 119 countries with people participating, but all countries globally work together in that community to actually go further together, right? That's what I would love to have happen. For me, that there is work to do. You know, we continually evolve. Healthcare gets more complex, you know, omics and advanced research and all sorts of other things. We need to continue the good work. But really, this is about a convergence of data globally with the other standards to actually enable all of the things that we just talked about. And for me, AI is another big thing. So, you know, I sit on the UK government's AI Council. I've done a lot of work in AI. What my real hope is in the next few years, that we can safely enable AI to be part of the augmentation in our health systems, to make, you know, clinicians' jobs easier, to plug the gaps that we've got in resource because demand is outstripping capacity, and to actually create the next generation healthcare system. And so, you know, the next few years for me within openEHR is to make sure that we are playing our part towards doing that, and that we're working towards, you know, a future with the other standards bodies that allows health systems to really make progress and deliver value and safety and quality. So it's really exciting. It's, you know, it's a bit crazy trying to take on global healthcare, isn't it? I mean, you know, but at the end of the day, it's really worth doing. You know, data saves lives. I was involved in the Data Saves Lives movement. Prof. Ian Buchan and others in Manchester worked on that. And we had this account of lives saved or improved as we improved data. That was very real for me at that moment. And I can now see this on a global scale. So I can't think of anything really much more worthwhile than, you know, growing this community and actually getting to that real safe point, as I said, like with aviation and other industries, where we know that we have safe data that supports human health. Yeah, that would kind of be my dream for where it would go.
Yeah, I think it does feel like a big project to be taking on, in inverted commas. But on the other side of that, I think where it will suddenly start to march off into the distance ahead of the existing suppliers is when the feature set is just something that they can't touch. So openEHR powered data systems where they can all run on the same data and have that sort of hot swappable interfaces on top of that data. The feature set of that will be so far and away ahead of what we currently have that it will transform the system. So nobody will be able to compete with openEHR powered systems, or at least systems that have an interoperable data layer, because you'll be able to have a UI that's specifically for GPs that operates on that data layer, but then you can have a different UI that's specifically for health trainers that uses the same data, and you can have research UIs that operate on the same data, and everybody's looking at the same data, but they might be looking at it in the way that suits them for their job, for their role, and that flexibility is not something that can be delivered using the systems of the past.
Absolutely. And I mean, you look at One London now, we have citizens of London writing to openEHR via the NHS app around their care plan, right? This is every actor in the system, including the patient and potentially their carers, right? So health and care, it is a single layer that allows, as you said, it's really, an ecosystem of different applications that can be hot swapped on top. And that's, you won't be able to compete with that in the future. Some of these vendors may embrace this. We don't know, that would be fantastic. But really what the difference is the vendor lock-in and providing a closed ecosystem from one or a small select vendors versus health systems and citizens owning their data and being able to curate what sits around, which makes a more evergreen world, actually, because you're able to, iteratively update your suite of applications that sit around this, as opposed to having to do these big monolithic upgrades to software that is written for, a huge sort of community. So you probably haven't got what you want in it. And so I think the flip side of this open data is the ability then to create more localized experiences on top of it. Yeah. And thinking about different communities and their needs. I've been doing quite a bit of talking about social determinants of health and also nudges and looking at how we work with different demographics within different populations. Really, the variance needs to be in that bit. It needs to be in how we reach out to the end human and making their experience optimal, and that will be a lot easier and simpler over an open data layer, as opposed to buying the data and the application from one vendor who have one experience, very little variance in it. So it's almost standardize the data to be able to vary the experience for your end people to get better outcomes. And that's kind of the equation as I see it.
I think that's got to be the way forward. And I've heard this separating data from the application phrase now being used by people in government and in sort of the upper echelons of the UK NHS. But I think that although they've cottoned on to the fact that it's a virtue, they don't know how to bring it about. So they are sort of trapped in that thing. They know that it's something they should want, but they don't seem to know how to make that happen. And they still keep falling into the same vicious cycle of going back to the same vendors and saying, can you make us fully interoperable, please?
Yeah, I think you have to be the owner of the data. You have to be the intelligent client for the data as a health system. And that's not something that's traditionally happened, right? You've not, if we look at healthcare, not everyone has a chief data officer or a data catalog or any of those things. Data management hasn't really been something that's taken off in healthcare traditionally. And we need to move into that space because that data is an asset that we can leverage in many ways. Population health, risk management, healthcare planning, all of the things that we can do with that data as a health system, which help it to operate more, efficiently and effectively. So to a degree, I think parts of health systems like the NHS don't know how to start eating the elephant in some ways. There are some places that are doing a brilliant job of it, but some places that just aren't in that space yet. And that, to a degree, is a maturity and education piece. It's something where we have to move into the new space where data is critical infrastructure. And that's a maturity sort of curve. But one thing that I'm, really keen on is designing data-centric health systems, where you look at your data first and then you look at everything else around that. And that's not the way we've traditionally done it. So I think it's going to take time for that to emerge, but certainly other industries, they really see the data as a core and center of what they do. And I think we will get there on that journey, but I think it's, moving from where we've been, where we've not particularly owned our data, we just extracted bits of it where possible, through to really truly owning the data. That's a bit of a journey to go on.
Yeah, I think some industries don't actually know what you're talking about when you say interoperability to them, because they don't have an interoperability problem.
So yeah, it's interesting. So let's
we're
unpack
so far
that.
behind that,
Yeah.
that we do have to find the solution from somewhere. And I feel as though the openEHR is a vital part of that sort of recipe. So I'd love to have you back on the show, because I think there's quite a lot more we could talk about. We could go further and deeper into the openEHR standard and that sort of thing. I'm talking to Thomas Beale, who's one of the founders of the openEHR standard, in about a week. And so I think we might be into openEHR season, and we'll have a variety of different voices. But I'd love to have you back, Rachel, and talk further about the big picture here, because there's a lot to play for, and I think we touched on it. Let's bring that back in a future episode. But thank you very much, Rachel Dunscombe, for joining me. And I'll see you in the next one.
Yeah, see you then.